Our next presenter is Vivek Narayan. He's the Director of Product at RECOUP Health. Vivek is a vision-driven with the passion of understanding the application of technology to healthcare problems. And so he's a world traveler, Australia, India, the United States, known to bring system thinking to every project. RECOUP Health. Vivek, welcome.
Thanks, Oli. I'm Vivek Narayan. I do have a medical background, but I haven't seen a patient in a very long time. So think of me just as the Director of Products and Member Experience for RECOUP Health. It's a pleasure for me to talk about some of the work that we're doing in the what we're referring to as the integrative root cause rehabilitation space. Lots of fancy sounding words. Hopefully that'll make some sense once I go through the presentation. Before we begin though, I would like to thank the InnovatorMD team, Uli, Ruchi, Anadya, for giving us this opportunity, and of course to the broader group for giving us your time and attending the presentation. Broadly, the presentation is divided into kind of two phases. One is a little bit of context into RECOUP and how we've got here and why we're focusing on cardiac rehabilitation. But secondly, as I was discussing with Uli, I'm like, hey, what do you think is the most useful thing for the network? And part of that was to work with startups and kind of, open the lid on some of the ways in which we approach startups and how one builds product, and a little bit of market research and a little bit of this and a little bit of that. And so the motivation here is twofold, right? So we're looking for collaborators. We're looking for cardiologists that we want to work with, but also we're looking to contribute into the ecosystem. So, if there's questions, if you'd like to understand how we approach pilot programs, how we design clinical operations, I'd be happy to connect and, share with you our knowledge, my personal experience. So that's our contribution into the ecosystem, so to speak. RECOUP Health is a US-based healthcare startup with operations both here in the US in the Bay Area and in Bangalore and in India. In a previous life, RECOUP had about 80 centers across India with an apex super specialty inpatient center in Bangalore. And the focus was on musculoskeletal and neurodevelopmental disorders. COVID forced us to start delivering care online, and most of the physical infrastructure had to be closed. As the world started recovering from COVID, our founders got together and kind of imagined what healthcare should look like after COVID. And what emerged was a belief that we should be focusing our efforts on rehabilitation and preventive care. And those were really based on some of the learnings that we experienced during COVID, right? And so I'll describe what some of those learnings were, and this really informs how we're approaching clinical care. And you'll see that how we're approaching clinical care actually kind of overlaps with some of the stuff that Omar mentioned. And it's interesting to hear commonalities in some of these themes, right? So broadly, some of the lessons that we learned, at least. We were able to deliver effective virtual care, but patients still like to interact with humans. So what we're doing is we're choosing to retain those in-person interactions that derive value for patients, but we're digitizing everything else, right? In a rapidly changing environment, even providers find it hard to keep up to speed with technological and medical advancements. And so to support our providers, we're basically leveraging the state-of-the-art technology to create clinical decision support. Now, in today's world, that happens to be AI, but we believe that technology is a way in which you facilitate patient-provider interactions. And so a clinical decision support that allows providers to understand what the root cause is of a patient's illness is the best way that they can then focus on just patient-provider interaction. So focusing on the patient and making sure they're developing that rapport and that connection with the patient. Work from home and hybrid work setups have increased awareness of musculoskeletal issues. But and this is something that Omar mentioned in his presentation as well, along with that, though, there's an increased understanding and awareness of the mental health aspects of isolation and loneliness. People, I think, almost universally now recognize that there's an interplay between what has often been called as the mind-body continuum. So our approach really addresses patients holistically, and we recognize that physical and mental health are really two sides of the same coin. This is more emerging. There's evidence that suggests that there are long-lasting health disparities in subpopulations. So let me give you an example of what that means. It seems to be that at least in South Asians, cardiometabolic diseases are now, the incidence and prevalence is increasing, and they are affecting, South Asians are generally affected with cardiometabolic disease, but it seems to be that they're now being affected at a younger age. And to address that, we think that screening, preventive health, and rehabilitation will make an impact on these health disparities. And different subpopulations are going to have their own health disparities. Cardiometabolic health is just one example. In the absence of drugs that treat disease, people will turn to non-pharmaceutical interventions to improve their health. We think this has led to a greater awareness of lifestyle medicine and treatment regimens that don't rely on drugs. And finally, if the concern is high enough, everyone understands prevention, even if they need an app to remind themselves to wash their hands. Now, this is a little bit of an inside joke. I grew up in a background with doctors. I went to med school in India. I practiced in India. Hand washing is one of the most basic things that we learn, but you'll be surprised in Western countries, people don't think hand washing until before COVID at least was something that could be used to prevent disease. And so we think that COVID has really pushed an understanding of what preventive disease can be. And so we think that patients are looking to adopt healthy behaviors and are willing to engage with preventive measures now so more than before. So all of this has sort of led to what we're calling the 4 Rs of clinical care, at least for us, where we focus on relief of the patient's symptoms, immediate. So provide immediate relief to a patient's concern while we build our trust and we're continuing to interact with the patient. We apply a systems approach, and I mentioned that tech-enabled clinical decision support to identify the root cause of a patient's concern. We apply what we refer to as a 360-degree approach, to address the root cause and correct any imbalances in both physical and behavioral health. I don't like to use the word mental health. That has connotations associated with it. What I'm referring to is, habit hygiene, healthy habits, behavioral health, so to speak. And then finally, support the patient's progress by ensuring the patients don't relapse into lifestyle choices that can potentially have a negative impact on their health, and attempt to reverse as much of disease progression as possible, both improving health span and lifespan. So that's the sort of regenerate portion of the 4 Rs. So we said, okay, great, we have a system. How do we go about testing it? And so late last year, we conducted a 12-week pilot program. In the program, health coaches, with the help of physicians and a clinical decision support, created personalized care plans for each patient. Progress on goals was reviewed weekly. And what you're seeing in front of you is basically the results. These are patient-reported outcome measures as measured by the MSQ, which is a multi-symptom questionnaire. We're reporting a statistically significant reduction in the severity and frequency of the patient-reported outcome measures. And this was actually a poster presentation that's been accepted for the Institute of Functional Medicine's annual international conference in Vegas. So I'm off to Vegas in a couple of weeks' time to do this poster presentation. Yay, me. Notice the dramatic reduction in musculoskeletal and lower GI symptoms. We believe this data demonstrates that we've been able to figure out that, this is what the root cause is, and we've been able to create interventions that ameliorate these concerns with specific and measurable interventions, right? Now, the interesting thing over here is, and hopefully this connects to the later part of the presentation, which is since most of these patients have had known chronic diseases where their current healthcare provider wasn't able to address their concerns, if we take a step back, what we've really done is an understanding, and an understanding has emerged about how to create and operationalize a very interesting rehabilitation program, right? So I wish I had seen Irina's slide before around how to pitch. I may not have included this, or I would have changed the structure of this slide. But look, there's a large market over here. Whether it's chronic pain, chronic diseases, or mood disorders. The point I'm trying to make over here is the direct costs associated with rehabilitation are less than 1% of the amount that is being invested in what seems to be intractable disease states. So we believe that there's a tremendous opportunity to attract market share and operationalize something that would have a true impact on patients. So in short, Recoup wants to improve the quality of life for our patients. We want to reduce the burden of disease for patients, providers, and payers, that triple P that we all want to talk about. And we think that the best way to do so is to deliver integrative root cause rehabilitation and preventive care. So with that context, I'm actually going into the cardiac rehabilitation program. Ruchi, keep me honest around time. Do I have 5 more minutes to get into that program? If so, just give me a thumbs up. Oh, yeah, cheers. Okay, awesome. Non-pharmaceutical interventions improve post-surgical outcomes. What you're looking at is basically the determinants of quality of life after a coronary artery bypass graft, or CABG, as we like to say. And what you can see, it's not just about pharmaceutical interventions. It's not about the quality of surgery, but it's really about internal and external factors, right? Self-efficacy, concept of self, mood and mental health, sleep, all of these things have an impact on the quality of life after an acute or post-acute intervention. What you're really seeing over here is the need for an integrative approach to rehabilitation, cardiac rehabilitation in particular. We're sort of referring to this as rehabilitation plus, right? So for us, interdisciplinary care involves nutrition, physical, mental, and behavioral health. It's led by physicians, but where health coaches are, they're sort of like a patient's trusted accountability partner. They shepherd individuals along in their journey towards better health. And Omar in his presentation mentioned readiness to change. We're also using concepts of readiness to change, where we can then titrate the aggressiveness of a patient's goal depending on where they are in their particular journey. So we look at readiness to change as an indicator of where an individual is on their healthcare journey. Diving deeper into the program itself, what you're seeing is an example sort of illustrative outline of a session, right? Our program is designed in such a way that patients graduate with the knowledge they need to look after themselves and achieve sustainable results, right? How does one do so? We think the way to do so is to completely protocolize a goal-oriented approach that addresses all aspects of the patient's health. So each session has an action item. It leads to specific outcomes. These outcomes line up with the weekly and monthly goals of the program. So from our perspective, cardiac rehabilitation is interdisciplinary, it's goal-oriented, it's comprehensive, and ultimately it's sustainable. Patients graduate and go away. We don't necessarily want to see them after the duration of the program, but they're welcome to come back. Mechanics of the program, what we're looking to collaborate with cardiologists. Once referred to us, patients can choose to participate in a cohort by registering, providing consent, answering a few basic questions. We send them a welcome kit that has everything they need for the rehabilitation program. The first few sessions of the program are designed to baseline the patient, educate them on what to expect, give them the skills they need to hit the ground running on rehabilitation itself in the intensive rehabilitation phase. They have weekly coaching sessions, same-day chat with the care team, a self-serve library of personalized education content around some of those interventions that we were talking about. On the back end, we have dedicated case managers and health coaches who work with the patient and coordinate care between various stakeholders. So while there may be many specialists on the care team, everyone speaks with the same voice to the patient, right? That way the patient and the provider team is kept abreast with the progress that's being made. But more importantly, many minds can come together and problem solve when the patient hits a roadblock. This may seem familiar to some people, but what you're seeing really over here is a clinical decision tree of sorts. A variety of patient data gets organized to understand areas of focus. So in other words, what's the root cause? What are the triggers? What increases or decreases a particular physiological pattern? Does the patient need to improve lipid burden as an example, or is there issues with autonomic overdrive? Understanding what the main concern is then, and then applying predominantly non-pharmaceutical interventions to that, right? Specific interventions, anything from sleep, movement, nutrition, behavioral health, and we're always driving for an outcome which is measurable in either subjective or objective measures. So I love that Omar brought that up. It made my heart sing when I heard that. We've got a library of interventions that we can apply to the patient based on which stage they're at. And again, as I mentioned, the effectiveness of each intervention is measured, whether it's device-based or score-based or patient-reported outcome measures. Overall, we've created a 6-month rehabilitation program. We're currently working with I'm going to refer to them as an Ivy League teaching hospital in New York, but we're looking to expand that network of referring cardiologists. We've created a 6-month rehabilitation program. The first 3 months are the intense rehabilitation phase. The latter 3 months are more about relapse prevention and maintenance. In the rehabilitation phase, patients will have access to a range of experts, undergo weekly and in some cases bi-weekly sessions. I'm over time.
Check.
All right. Let me finish with a call to collaboration. This is just the beginning for us. So if you're a cardiologist looking to improve your outcomes, or if you're a caregiver looking to make an impact, we'd like to work with you. So with that, I'll take any questions if we do have time. So thank you.
Any questions for Vivek? I have a question. Is this all going to be a virtual program?
Uli, yes, for the moment, it is a virtual-only program. But at some stage, we're thinking of how we're going to open our next clinic over here. As you know, the group obviously may not know, but we have 2 clinics that have opened as pilot sites in Bangalore. And so learnings from there will inform when and how we open a clinic up here. But at the moment, it's virtual only. Yeah.
Okay.